The benzodiazepines differ in their kinetic profile. Some of these drugs have very long serum half-lives, upwards of 90 hours. The duration of action, however, the actual measurable production of sedation or the reduction of anxiety, however, is much shorter. It could be several hours to several days, depending on the drug. And that's because there's a concept here that we need to kind of review back from earlier courses, and that's redistribution. So these drugs redistribute quite readily from brain to fat or muscle tissue. So we can differ some of the benzodiazepines based on their duration of activity, and that activity is measured by how much sedation or hypnosis they can produce. And so the long-acting drugs can be 1 to 3 days, and these often, ironically, are the least lipophilic, whereas the short-acting drugs, which are only 3 to 8 hours, are extremely lipophilic. So this would probably seem counterintuitive, so stay with me for a moment, because part of it comes down to half-life. And so, in order for a drug to obviously produce its clinical effect, those drugs that have long-acting, long durations of activity usually have longer half-lives, and that is correct. But determination of a drug action in the context of the CNS specifically is really a context, or a consequence, I should say, of redistribution. That is because, back to the volume of distribution, we always said that the larger the volume of distribution, the more lipophilic the drug is, and that certainly is true. But very large volumes of distribution tend to go to the brain very quickly, but they also leave very quickly. Okay, whereas drugs with maybe slightly smaller volumes of distribution take some time to get into the drug, into the brain, but they don't leave quite as readily. And so I think this is kind of a good visual representation of lipophilicity. And so the greater the lipophilicity, or the greater the volume of distribution, the more quickly the drug enters, but then it leaves very quickly. So that means the duration of activity is going to be relatively short, because it basically goes into the brain and leaves the brain. Remember, the sedation component to these drugs only really counts when the drug is here. It does not count when the drug is here in the adipose or the muscle tissue. All right, and so drugs with relatively moderate volumes of distribution outside of normal body water, of course, will take some time to enter the brain. But once they enter, they will stick around for some time before they redistribute to fat and muscle. Okay. So lipophilicity and volume distribution is one component to explain why some benzodiazepines have a very long duration of activity and why other benzos have a very short duration of activity. The other reason for these possibly extended half-lives include enterohepatic recirculation. And so remember that as the drug gets biotransformed or metabolized, of course, this is an orally administered drug, gets absorbed to the bloodstream, goes to the GI system, ends up in the liver, and basically a large portion of that drug gets recirculated through the portal circulation and goes into the liver system. And because there's numerous CYP enzymes involved in the biotransformation of these drugs, a large portion of that dose gets converted into something else. Some of those other metabolic byproducts have longer or shorter half-lives than the parent compound. So this is portrayed nicely in another slide or so. And so the concept here that there are, most of these benzodiazepines have very strong CYP metabolic profiles, except three in particular. So the three that are metabolized or biotransformed outside the liver include oxazepam, temazepam, and lorazepam. And the way you can remember this is, in their proper order, to remember outside the liver, OTL. This is very STEP relevant. STEP loves to talk about this. And so these are the 3 drugs that are safe to use in patients with liver disease for whatever reason. The other drugs, the other benzodiazepines, outside of these 3, have dramatic biotransformation reactions, and a lot of these reactions reflect the different half-lives that, when you add them together, produce the duration of activity. And so you don't need to know, obviously, that diazepam goes into desmethyldiazepam, which then gets converted to oxazepam. You don't need to know all this. But this just shows the complexity of some of the chemistry that's involved with these reactions. The bulk of the metabolism occurs through the CYP-P450 enzyme system. And the resulting active metabolites, so something like desmethyldiazepam and alpha-hydroxy metabolites that are related to the alprazolam version, these produce clinically significant effects. So these reflective active metabolites, some of them have a longer half-life or a shorter half-life than the parent compound. And so when you've got multiple doses, you can see something like residual drowsiness or residual loss of muscle coordination and some of these other benzo type of effects. Lorazepam, triazolam, and oxazepam in particular have short half-lives, and they are metabolized into inactive metabolites. And these drugs also have the least residual drowsiness compared to the other drugs in this category. Now, the benzos do have side effects, and the side effect profile varies whether or not these drugs are used alone, acutely, chronically, or with other drugs. Okay, and so when these drugs are used alone, there are relatively minimal side effects. Ironically, they do have a large therapeutic index, meaning that they are quite safe. And of course, remember, a lot of this is due to the fact that in order for this drug to work, there has to be endogenous GABA neurotransmitter available. If GABA, for whatever reason, is depleted or not available, these drugs do not have an effect. Almost all of these drugs produced retrograde grogginess, or a little bit of what can be deemed as a benzo fog the following morning. And most of them produce some degree of amnesia, which, again, could be good or bad depending on the severity. So typically we give benzodiazepines before procedures that are uncomfortable or embarrassing for patients to undergo. So think of a colonoscopy. Okay, the positioning of the patient, the actual process of a colonoscopy, it's a little embarrassing, both for the patient and probably for the first-time healthcare worker as well. And so, you don't want the patient to remember that. And so a little bit of amnesia is good. There are numerous drug-drug interactions, specifically with CNS drugs, where even acute short doses of benzodiazepine to reduce anxiety may be problematic. In terms of the chronic side effects, we do not see major CNS depression in the acute phase, but we can see CNS depression when combined with other drugs. And there is some dependence liability with these drugs. And so even though they don't officially alter dopamine levels, and you'll learn about dopamine and its role in dependence liability, there is some situational use with benzodiazepines, especially for patients who are relying on them for sleeping aids. And so, there's that component as well. And so the side effect profile really kind of depends on how the drug is administered and how long the drug has been taken. So to that effect, these drugs are relatively safe in terms of respiratory depression when given by the oral route. Okay, they have a relatively large therapeutic index. So here's the incidence of respiratory depression. The higher you go, the worse you are on this chart, leading to death up here. So oral benzodiazepines really don't get to the 50th percentile, even in large doses, because they have a high therapeutic index. When you combine oral benzodiazepines with ethanol, that therapeutic index, that safety profile is dramatically reduced, and you can see an increased respiratory depression because now you're combining alcohol plus benzos, which are both sedative hypnotics. When you give IV benzodiazepines, that has the smallest therapeutic index, of course, and that's got the highest incidence of respiratory depression leading to death.